Dear colleagues, I shall discuss today an important aspect of control of diabetes. Conventional tests which are done, why there is a need for new tests, and what is exact role of fructosamine and glycated albumin as glycemic control measures. Objectives of this presentation are to appreciate the need for assessment of glycemic status by an appropriate test, to understand the value and limitations of hemoglobin A1C, fructosamine, and glycated albumin in assessing diabetic control, and to identify conditions in which there is a greater role of fructosamine and glycated albumin for monitoring control of diabetes. Now, currently, there are two types of tests which are available for monitoring diabetes. One is point of time estimate of blood glucose, that is called as capillary blood glucose, which is done as home glucose monitoring. It can also be done by withdrawal of blood intravenously and getting the test done in laboratory. However, for a period of time tests include continuous blood glucose monitoring for days to weeks, which may estimates the interstitial glucose levels. The second one, which is more established, is glycated hemoglobin, known as hemoglobin A1C, which gives an approximate value for 2 to 3 months average. Apart from these two tests for period of time, fructosamine and glycated albumin have been found to be useful in certain conditions, and there is an emerging role of 1,5-N-hydroglycetol. In this presentation, we will identify conditions where there is a role of fructosamine and glycated albumin. Now, when we estimate plasma or capillary blood glucose, so it is a point of time glucose estimate, but it is useful to detect hypoglycemia episode immediately in a short period of time. And it is also useful to adjust the dose of short-acting drugs. And finally, it promotes patient adherence. However, there are limitations because of frequency of testing, pinprick, and cost involved. However, with technological advances, hemoglobin, home blood glucose estimations are become more operable and easy to do because of small instruments and smaller prick with almost pain-free capillary blood withdrawal. And hemoglobin A1C level can be correlated with capillary blood glucose, and a formula has been given by American Diabetic Association to estimate. Patient can himself or herself estimate the level of hemoglobin, level of glucose from the level of glycosylated hemoglobin by this formula, that is 28.7 multiplied by level of percentage of the hemoglobin A1C, and then the product is minus 46.7. Continuous blood glucose monitoring has become more uh, approachable, easy, doable, and this is done for weeks or days and for personalized diabetic care. It requires wearing of the monitors which continuously estimate interstitial glucose levels. So it is somewhat cumbersome, and some degree of diabetic education is required for its application. Now, hemoglobin A1C is a time-tested and reliable test to diagnose and monitor diabetes mellitus type 1 and type 2. Since glycation is a continuous process, it will give an average glucose value for 90 to 120 days, which is the lifespan of red blood cells. Now, during adequate control, Monitoring is done by estimation every 3 months, that means 2 to 4 times a year. And its levels correlate very well with the control and complications of diabetes mellitus. However, there are many limitations of hemoglobin A1C. It does not detect or provide accurate estimate of frequency or severity of hypoglycemia. It will just give an average of up and lower values of glucose during the period. In pregnancy, it may not depict postprandial hyperglycemia, which is correlated with macrosomia, that is, overweight babies. Hemoglobin A1C gives an average of high and low levels of glucose only. Low diagnostic value of hemoglobin A1C in pregnancy and elderly have been reported. Risk of overdiagnosis is there in iron deficiency anemia because levels vary according to the RBC turnover, if it is high or it is low. And always suspect some degree of hemoglobin disease if hemoglobin A1C is more than 15%, because mostly levels vary between 5% to 12%. Now, there are again other uncertainties as regards hemoglobin A1C. Genetic hemoglobin variants such as hemoglobin S and C traits or elevated fetal hemoglobin along with chemically modified derivatives of hemoglobin in chronic renal failure. One of them is carbamylated hemoglobin. They all can substantially reduce the accuracy of estimation of hemoglobin A1C. And there is also uncertainty in subjects with diabetes who have increased red cell turnover due to hemolysis, major blood loss in athletics, and end-stage renal disease, or those diabetes who consume heavy alcohol. Lipemia, uremia, bilirubin levels in the blood may also interfere with assay depending on the type of the assay used. And there is an analytic imprecision which can be really significant if these conditions exist and hemoglobin A1C is estimated by other methods than HPLC. So these points are to be taken into consideration when we receive a report of hemoglobin A1C in patient of diabetes who is considered to be either controlled or uncontrolled. Now, to sum up the conditions in which hemoglobin A1C levels will be variable include common and uncommon disorders such as asplenia, chronic renal failure with or without hemodialysis, chronic liver disease, hemoglobinopathies, hemolytic anemia, pregnancy, and untreated iron deficiency anemia, and its deficiency of B12 and folic acid. Transfusions also cause variability in the results. Now, under these conditions, when such variability is expected, control of diabetes becomes difficult, and then there is a need for some other test. Now, one of the chemical which can be used is fructosamine. Now, fructosamine chemically is a ketoamine, stable ketoamine, full name 1-amino 1-deoxy fructose. Now, glycated albumin is also a ketoamine which specifically involves albumin whose levels in blood are 3.5 to 5 gram percent. Glycated albumin is thus an example of fructosamine which estimates total proteins actually. Now, fructosamine and glycated albumin can be utilized as short-term markers of glucose control, and both correlate significantly with hemoglobin A1C levels. We know albumin can bind with metabolic products, which includes glucose, drugs, and free fatty acids. And glycation is a process of non-enzymatic formation of an intermediate through Maillard reaction. In this reaction, glucose reacts with arginine and lysine residues of albumin and other proteins. This initial reaction is condensation of free aldehyde group of the sugar, that is glucose, with N-terminal amino acid of the protein to form intermediate shift base, which is called as albumin intermediate. So Maillard reaction forms albumin intermediate, which have two fates. One is either it gets reconverted back into protein and glucose, or it will, depending on the level of glucose, this albumin intermediate will undergo amidori rearrangement and will form stable fructosamine, which is a ketoamine. Now, fructosamine refers therefore to all ketoamine linkages formed in this way with the proteins. And total fructosamine is glycated albumin, glycated globulin, and glycated lipoproteins, which are total proteins of the blood. Since albumin is a major plasma protein, glycated albumin constitutes about 70% of the total fructosamine, and it can be used as an independent measure of glycemic control also. Half-life of the protein we know is about 7 to 21 days, whereas that of albumin is about 20 days, as against 120 days of the RBCs. Therefore, measurement of fructosamine and glycated albumin will give an estimate of average level of glucose for about 2 to 3 weeks. Now this is intermediate period and period of time which is less as compared to that which is provided by glycated hemoglobin. The rate of glycation of albumin is considered to be faster, 9 to 10-fold higher than that of hemoglobin. So it will give quicker results actually. Now, as I discussed earlier, there is a relationship between fructosamine and hemoglobin A1C, both in same direction, and therefore hemoglobin A1C percentage can be estimated, or fructosamine levels can also be estimated. For example, 317 micromole per liter of fructosamine, which equals 7% of glycosylated hemoglobin A1C, whereas 375 micromole per liter fructosamine equals 8% of hemoglobin A1C. The relationship between glycated albumin and hemoglobin A1C is straightforward. The level of hemoglobin A1C will be almost one-third of glycated albumin. So now we can really understand why is there a need for estimation of fructosamine and glycated albumin. This is because they are not affected by hemoglobin levels or red cell characteristics to which hemoglobin A1C is susceptible. Normal fructosamine levels are considered as 200 to 285 micromole per liter at the serum albumin levels of 5 gram, whereas normal glycated albumin is expressed as percentage of albumin which is glycated, and that is 14 to 15%. Any level which is above 17% is considered to be in diabetic range. Now, a negative correlation has been reported between glycated albumin and body mass index. Therefore, glycated albumin may underestimate glycemic control or levels in obese diabetics. For fructosamine, there is greater susceptibility of albumin to glycation than intracellular hemoglobin, and that makes it an intermediate measure of the glycemic controls. Therefore, fluctuations in the blood levels of the glucose can be found with estimation of fructosamine or glycated albumin. Because it is a short period estimate, so the levels rapidly decline. Levels of glycated albumin rapidly decline than that of hemoglobin A1C when intensive insulin therapy is administered. Therefore, in conditions of low utility of glycosited hemoglobin as an index of glycemic control, fructosamine and glycated albumin can be used as alternative measures of the glucose control. Now, few conditions in which fructosamine can be useful is the short-term estimation of glycemic control after diet and drugs to assess glycemic control at the time of conception in diabetic women who recently became pregnant and patients with hemoglobinopathies such as sickle cell disease, hemolytic anemia, or recent blood loss. This can be a useful measure. Now, in the diagnosis and screening of diabetes mellitus, there is an overlap of the values of fructosamine between normal and diabetic. Therefore, anything which is 286 up to 286 micromole is considered to be normal. However, a level of 268 to 870 micromole have been reported in diabetic uncontrolled patients. Therefore, this is a major limitation. And more studies are required to be done to identify the level of fructosamine that differentiates a diabetic versus non-diabetic. However, these two tests can also be done for therapeutic monitoring of diabetes in conditions where hemoglobin A1C is less reliable. It also is a useful measure for estimation of postprandial hyperglycemia, which itself is a risk factor. It is also useful in gestational diabetes in certain conditions and chronic renal disease in diabetics. Now, in the screening, as I discussed earlier, the glycated albumin and fructosamine can be used in place of the hemoglobin A1C estimation. Now, they estimate and provide an idea about the future risk of diabetes, which is independent of fasting plasma glucose and hemoglobin A1C. And therefore, estimation of glycated albumin can identify people at risk of diabetes without considering hemoglobin A1C also. And anything above 17.1% is considered as the most efficient threshold for performing confirmatory oral glucose tolerance test in pre-diabetics or in suspected diabetics. It is also reported that fructosamine discriminates subjects with or without diabetes with a threshold of 2.5 millimoles per liter, which is much higher, of course, with sensitivity 0.61 and specificity 0.97. Therefore, these are the situations where estimation of glycated albumin and fructosamine are useful. However, one must note that fructosamine concentrations may overlap with the normal range of the test. Therefore, this makes it less useful screening test. There is a special role in gestational diabetes because hemoglobin A1C exhibits biphasic changes. Initially, it decreases for 6 months and then it increases in the third trimester. This is because of rapid changes in RBC, the B12, folic acid levels, protein levels. And therefore, glycated albumin can offer an alternative to assess diabetes in pregnancy and to diagnose diabetes and to identify the pregnant mothers at risk. Now, role in chronic renal disease. Anemia of chronic kidney disease is associated with increased red cell turnover. So, there will be higher hemoglobin A1C level. And if we use erythropoietin, iron or transfusions in CRF, then it makes hemoglobin A1C less reliable because low levels will underestimate the control. In this condition, glycated albumin accurately shows glucose homeostasis in chronic renal failure because it is unaffected by anemia. Unlike glycated albumin, a large number of clinical trials have reported poor correlation between fructosamine and glycemic control in renal disease or patients with on hemodialysis. Therefore, there is a better role of glycated albumin than fructosamine in chronic renal failure. Now, if levels are too high, then one must suspect hemoglobinopathies. Hemoglobin A1C level greater than 15% is very unusual and it is inconsistent with the sample plasma glucose levels, and then we must suspect that there is some underlying RBC pathology or disease. Apart from the role of fructosamine and glycated albumin, one more chemical compound, 1,5-anhydroglucitol, is also now being studied as a measure of diabetic control. Now, this is a polyol obtained from dietary sources and it competes with glucose for reabsorption in renal tubules. In glycosuria and hyperglycemia, circulating levels are lower. So this being studied that if the levels are low or high, then we must find the reason for that. In low levels, maybe because of poor diabetic control. Now, limitations are it has low reliability because changes in renal function will alter the blood levels. And when patients of diabetes who are taking SGLT2 inhibitors, dapagliflozin, etc., then these drugs themselves cause glycosuria, so the levels of the anhydroglucitol will vary. Therefore, at present, it is being better understood how it will be useful and in which conditions it will be useful measure for glycemic control. Now, one more aspect of fructosamine is that the fructosamine has a limitations, and this is because of changes in the plasma proteins, particularly immunoglobulins, which can affect the fructosamine levels. And vitamin C interferes with fructosamine assay, and therefore patient should not take vitamin C 24 hours before testing. So the key points are hemoglobin A1C is a reliable but not a perfect indicator of glycemic control. Its levels vary in disorders of RBC and renal disease. Fructosamine glycated albumin are useful alternatives to hemoglobin A1C in such conditions where later has lower reliability, and there are advantages and limitations of estimation of fructosamine and glycated albumin. Thank you very much.